to a proposal on PCMH was put together by some of the people on this task force, and John's going to be going through his assessment of that from a cost-saving standpoint today. So this is our last opportunity to kind of ask questions, where John's going to be at the end of the table with his team before we need to make our votes next month. So hopefully everybody can kind of see where that's headed, and then next year the task force will be into the implementation phase. As we know, John's contract was re-up for help there. Obviously, the governor and DHS and the legislature is going to need some assistance from us along the way, so our role will really shift much more to an assistance on the implementation next year. Senator Bledsoe, did you have anything you'd like to add?
No, thank you.
Okay, so with that, we will go to our agenda, item C, consideration of the minutes. Can I get a motion to approve the minutes? Senator Chesterfield, I see a second from Senator Sanders. All in favor? Any opposed? The motion passes. Next, we'll move to item D, and what we're going to talk on now are follow-up from questions on the November task force. So, John, if you and your team would just introduce yourself again for the record, then you are all recognized to talk about the follow-up questions.
John Stephen, managing partner for the Stephen Group.
Rory Rickert, senior consultant with the Stephen Group.
Richard Kellogg, senior consultant with the Stephen Group.
Thank you, Mr. Chair. If I may ask Phil, if we could have the woman that fixes the computer here to maybe come and make sure that this computer doesn't restart in 7 minutes, because it'll create a little blimp, and we want to make sure we keep going. So for some reason, it says it's about to restart. Anyways, I'll get started. Today, we wanted to give you an update. So here are the issues that we're looking at today to talk about. And I like the fact that the chairman has indicated that we'll help you on the next meeting, make sure there's a report ready to go, and I know there are decisions that need to be made. Today, we're following up on a number of questions that you've asked us to review, and I'm going to go through as quickly as we can, and I know there's a lot of material here, and I apologize for that. I just know that there needs to be some decisions being made, as the chairman has said, and I want to make sure you have all the information you need. We'll be able to help you as we continue to do in making some of those decisions. So pharmacy savings, vaccination findings, we're going to talk a little about the lockout premium based on some of the questions that came the last meeting, marketplace update. I think Representative Meeks and Representative Gray had some questions. Nursing home census, Representative Farrar had a question. There's a number of contract care models, and then we're going to get into the managed care versus the PCMH issue. We've been asked to go and look at costing or look at the savings for one model versus the other to maybe go down into a little more detail for you. We're going to try our best. And again, you know, there's so many different models out there, and we'll get into that, and it's going to be something that you'll obviously be reviewing and deciding on.
And John, I just want to emphasize that all of the recommendations and things you're talking about are all building on or more elaboration of or specifics of things that were in the October 7th
Yes.
report. You're not introducing any new ideas. This is all stuff that
Correct.
is already in the report. Okay, thank you.
Correct. The only caveat to that, Mr. Chair, is the vaccination issue that Representative Boyd asked us to look at, and that's where Rory will start. I'm going to hand it over to him, and he's done a lot of detailed work for you. And we think that that's a really good issue that this task force uncovered. So I'm going to let Rory start with the pharmacy issues. Go ahead, I'm going to use this.
Good morning. Well, I think the task force has paper copies of the slides, so we'll just proceed till they fix the laptop issue here. I wanted to spend just a couple of minutes narrowing, reiterating findings and recommendations in two broad categories in pharmacy. So pharmacy savings opportunities that the task force should consider, and then some pharmacy quality initiatives put forth for your consideration. And then I'll spend a couple minutes, as John said, talking about vaccinations. In the savings area, there's two primary recommendations that that our group has made to bring forth savings for taxpayers, the state, and the Medicaid program. First is consider recontracting the retail pharmacy network. And most pharmacies in the state participate. Very important for healthcare access that pharmacies continue to participate. In our recommendation, we suggested considering 2 tiers of pharmacies. So pharmacies that are located in rural and underserved areas, much like CMS does with rural and underserved hospitals, could be paid a premium compared to pharmacies that are in urban and suburban areas where there likely is oversupply of retail pharmacy capacity. We've presented a range of savings in this area up to just north of $18 million, depending on how pharmacies are split, underserved versus urban, suburban, and also the depth of the discounts that could be achieved. Second cost-saving recommendation, this is just a reiteration again, was to expand the preferred drug list, the PDL. The department, DHS Pharmacy Department, has already taken steps to begin this. They're evaluating several multi-state pools for what's the best fit for them to join. This will expand the number of drugs and number of therapeutic classes covered by your supplemental rebate program, and depending on how far that expansion goes, could produce savings up to nearly $23 million on an annual basis. In terms of the quality initiatives in the pharmacy space, they fall into 2 buckets, those related to opioids, and the second group are related to the monthly pharmacy claim limits. So in the opioid area, we've recommended 3 things. There's an existing program that isolates an opioid prescription user who needs to get prescriptions filled for opioids, limits them to filling all their prescriptions at a single pharmacy. Then that pharmacist can coordinate their care, coordinate their medication regimens, and help them stay on track with good opioid care. We gave detail earlier and in the October report, but we're also suggesting adding provider lock-in. So those same kind of high opioid users would be limited to using only a single prescriber. And the best practice in the country is locking into a single pharmacy and to a single prescriber. So we're recommending that. And lastly, this one required legislative change or rule change, which I understand is also underway, and that's to allow the clinicians who work in the DHS who are trying to provide good population health for opioid users, to allow them access to the state prescription monitoring program database. And that's a database where prescribers and dispensing pharmacies make entries when they either order or fill an opioid prescription. And allowing clinical folks at the state to see into that data will improve the way they can do the first 2 things, the pharmacy lock-in and the provider lock-in. And the last, again, from the earlier report, recommendation we had was to eliminate the monthly pharmacy claim limits on maintenance medications. So medications that people require for ongoing treatment of diabetes, high blood pressure, other cardiovascular diseases should not be subject to an artificial claim limit. It's really a good investment in medical care to allow people with chronic illness to have access to maintenance medications. If that change is made, however, DHS should go back then and reevaluate the claim limits as relates to the non-maintenance medications. So if we allow more maintenance medications to go through the gate, we'll want to go back and take a look at what the appropriate number of claims per month the limit should be for non-maintenance medications. This is new, Chairman. This is new since the report, but we were asked to take a look at vaccinations here in the state of Arkansas. There's public data available at the CDC website, published on a weekly basis. We looked at that information and found that in children's, teens, and adults, that the state of Arkansas ranks very low in terms of vaccination rates. In fact, in children, I think there were only 2 states performing worse. Kentucky and West Virginia were performing somewhat worse than Arkansas. In teenagers, Arkansas was in the bottom 5 states, and also in adults, same. So we set about to see if we could help identify causality and maybe some recommendations to improve that performance. And all under the guise of, again, just like maintenance medications, vaccinations are a really good investment in public health. They're a really good investment in care. If you don't provide appropriate levels of vaccinations, you're going to have costs bubble out in hospitalization, doctor visits, all kinds of other expensive care. What we found inside the state was participation in the Vaccines for Children program, a national program where vaccines come free to providers. And associated with that program for kids up through age 18 is a administration fee, professional services fee of $9.56 per vaccination administered to a child. What we found in the adults is that the reimbursement to providers, either clinic, individual physician, the reimbursement for the vaccination and the professional services were combined into one fee. So they'd bill a single code, get back a single amount of money, and that would vary by the vaccination. We wanted to know whether that was common practice or not common practice, and we went and looked at other states. So in other states, your neighboring states, and we looked at states afar as well, we did not find it to be common to combine. In fact, we didn't find it in any state to combine the administration, professional administration costs and the cost of the vaccination together. So, and you'll see in our recommendation, we're recommending to split that. We did see, however, one exception to that. We did see in flu vaccination that it's quite common to combine the cost of the flu vaccine, the actual product, and the professional service. That was reasonably common, especially common when the flu vaccine is given in a pharmacy. We took a look at the private option carriers here in Arkansas. They too behaved like
Excuse me, I've got a question.
Sure.
Representative Gray, you're recognized for a question.
Thank you, Mr. Chair. Just a quick question. I actually met with someone yesterday who was working on a master's class, and their research was over immunizations. One of the things that was brought up to my attention was trying to figure out, and I'm not saying that we don't rank in the bottom, I know we do, how our rankings come about, because our state registry, it's not mandatory to report to that if you're 22 or older. So one of the things is the data, I think, would be more accurate and reflective of what we do if we made it mandatory for providers, pharmacies, Walmart, whoever, to actually put that data in the registry. Do you think that's something that would help us achieve our goals?
Without that, it's easy to, well, that explains on this slide, how could, several 100,000 adults in the state Medicaid program only have gotten 11,000 vaccinations in a year? So there has to be reporting and data issues. There has to be.
Okay, and that's one of the things that we thought that the vaccination rate's probably higher, but it's not required. So, and I'm not saying make the vaccines mandatory, just the reporting side of it. And that's part of meaningful use with CMS. Stage 2 requires you be able to transmit to the registry and WebIZ. And I know they're currently working on getting a lot more physicians to where they have that capability. I just wanted your thoughts on it.
Okay.
Thank you.
I was saying that the private option carriers in the state also follow the separate vaccination reimbursement being separate from the professional administration fee. So on to recommendations, to try to close out our recommendations on the vaccination program here. The goal obviously is to increase the rate of both kids and adults in the number of vaccines received per year. It is a multifactorial problem. but a lot of the things you could try to influence, health literacy, changing your public school entry criteria. There's a lot of tools and levers you could pull to try to affect vaccination, but if the beneficiary who wants to be vaccinated shows up at a provider who's not properly incented to either inventory stock the vaccine and to give the vaccine and be paid fairly for it, all the social things we could do are going to fall flat if the financial support's not there. So our recommendation is, number one, to separate the vaccination cost, the actual cost of the material, from the professional services to give it. Cover the full ingredient costs the best you can by using publicly available data about the cost of those vaccinations, and to arrive at a fair professional fee for a professional to do the E&M on a patient, make sure that they're not allergic to the vaccine or any components of it, and to prepare and administer the vaccination. The fee in the Vaccine for Children program has been the same since 2004. That fee probably could be reevaluated and possibly increased. We would expect just the change in this reimbursement mechanism and setting a fair fee for the professional services. We would expect this by itself to increase your vaccination rates here in Arkansas, and should be evaluated periodically and soon after you begin the change to see if it's working. Then and only then, if that didn't work, that single intervention, would we recommend going back and looking at the other sort of levers you could pull. So changing your public school entry criteria, adding public service announcements, those kinds of softer things. Primary recommendation is change the reimbursement. And that's it, John.
Any questions? All set? Okay. Thank you, Rory. There was a question on the lockout history. I think Senator Ingram had asked about the background, going back and looking at how some of the lockout, because there was current data that showed Indiana, which is the one state that has, one of a couple states that has an actual lockout, that it was real low in terms of the recent numbers. Well, we went back to the history and we looked at the 2012 report, and the key here is that the disenrollment numbers are still relatively low. You got to remember, most of the folks that are eligible for the lockout, again, 100% to 138, which is a smaller number of the 250,000+ pool in Indiana in the power account. But you're looking at, in the beginning of the program, as it ramps up, 3%, and 7% 2012. The most recent report we saw was a quarter, it was like 800 in one quarter, which probably around that 6 to 7% area for the full year. So you're definitely looking at less than 10% in a historical for a lockout provision. And remember, Montana recently received a waiver, but Montana does not have a lockout. They allow you to, if you don't make your premium, to come right back onto the program. So that's just one issue that we wanted to follow up for you. Any questions?
Representative Farrar, you recognized for a question.
Thank you, Mr. Chair. When you do a lockout on this population, administratively, what's the cost of readmitting these patients back in? Go through just like I said, the administrative cost of lockout, put them back in, lockout again, put them back in.
I mean, I think that, I don't know the answer, but I do know the administration issue we looked at for the premium assistance, which is what Representative Ferguson asked about. So that's coming up. Okay. There's going to be some administrative costs, but you can have the carriers that handle most of these issues, like in Indiana. Mm-hmm. You could end up doing it internally. There's different ways to do it, but I don't think that's going to be a big cost.
Okay, so you don't think the cost of locking out would outweigh the cost of actually keeping them on the premium?
No, I think that the key issue is in the lockout is going to be your uncompensated care, and something you all are going to have to consider, because some of these individuals are going to go and use the emergency room or continue to try to find ways to get to to access to healthcare.
And when, in Indiana, they locked them out to zero insurance, no insurance.
Yes, and Indiana is, excuse me, what, the question,
When you locked them out, they didn't have coverage of any kind,
correct, for a 6-month period.
6-month period. Could this, if we did, let's say we did a lockout, could we put this population, lock them out of insurance, put them back to the Medicaid system?
You
To
can do
protect-
whatever
to
you want in
protect
that
the
area,
providers
correct.
somehow.
They can go back to the fee-for-service program, yeah.
Okay, all right, thank you. Thank you, Chair.
And that would all have to be in a waiver. But again, I just want to make it clear with everyone that this is not, CMS approved this state because it was grandfathered. If you remember, the next state that went in to get a waiver like this was Pennsylvania, and it was refused. Montana just recently got a waiver approved on what some are characterizing as lockout. It is not a lockout. It is basically, if you don't pay your premium, you will no longer be in the program, but you can go back by immediately paying your premium and arrearages. Okay? This was Representative Ferguson's question on premium collection.
John, we've got a couple more questions. Representative Hammer, you're recognized for a question.
Thank you, Mr. Chair. John, could you tell us, do you know what the causes for the lockout were? Was it because they just didn't do their paperwork? Did they fail to meet eligibility? Or what was the reasoning behind why they got locked out?
Yeah, this was all for failure to pay the premium. And the premium is 2%. I think it's up to 2%.
And is the population
their
we're
income.
talking about in this scenario in Indiana, are they the 138 to 400, or what
So
percentage?
this is the 100 to 138.
Okay, which are traditionally the people that maybe didn't have the 2% anyway, and do we know what 2% equates to in dollars?
No, I don't have that exact number, but I can get that for you. It depends, again, remember I had said it depends on family size. So you could have a single, it's going to be a little more than someone who has a family of 4.
And I guess what I'm struggling with in my mind is on the, and I think people ought to be responsible for their actions, but if it boils down to they didn't have the 2%,
Right.
is that because they're living in the poorest population?
And I think-
And that 2% might as well be 200%?
So that's a really good question. And so I want to spend a minute on that because that's important for you all here. In negotiating the waiver, if you were to agree under THIP, we do recommend the lockout provision. And we did it because we talked about this last time about incentivizing these individuals. Remember, in the recommendation is if you do your wellness program, if you meet your membership agreement, if you do the things that you're asked to do, there's no premium. There's no payment of a premium. If you then have to pay a premium and you didn't do what you're supposed to do, and then you don't pay your premium, that's when this would apply in the recommendation that we had given you all. The other issue is you could do in your waiver negotiation, if you go down this road, is a hardship provision. And I would recommend you consider that. That could be different than any other state. And so it would meet your issue, Representative Hammer, if there are certain areas of the state, high unemployment rate, there's difficulties at the time, you could look at that. But that's no different than a hardship on welfare reform. There's already, we hear this 2-year, you have a 2-year lifetime limit in Arkansas for welfare. But there's a hardship provision built into that, and there's rules around that. So you could, again, you have that option available.
So the way the waiver would be written is that the only reason the 2% would come into play is if you didn't do something else that didn't have a monetary value attached to it, and as a result of that, that's why you'd get blocked out.
Yes.
Okay, thank you. Thank you, Mr. Chair.
Senator Elliott, you're recognized for a question.
Thank you, Mr. Chair. This is a follow-on to that line of question. Has there been a follow-up with this group to know what their reasons are for failing to follow through? Do we know anything about that?
It's a really good question. There was no research that I could find. I mean, we spent a significant amount of time trying to scour through a number of, articles. I, in fact, called the consultant that works principally for the state, and the only thing that they had told me was the non-payment was the reason, but nobody dug deeper. So to answer your question,
Yeah.
I don't have that type of research. However, I want you to remember, in the 100 to 138% of FPL, these are individuals that are making some income. And if it's below 100, it has not applied. In the beginning, in Indiana, they actually did want to make it applicable to 50 to 100. They dropped that, and it stayed at 100. And there's a question in my mind if CMS would allow any further lockout anyways. But the secretary, in a recent, some discussion she had at a recent event on lockout, she mentioned that she would have to consider each state's request based upon how the lockout provision connects to the state's rationale for what they're trying to accomplish. So that would all have to be in the waiver discussions.
All right, okay, thank you. It just seems that such a almost nonsensical thing to put yourself in a position to be locked out, that there just must be something deeper that would be worth knowing, although I understand nobody has done that.
But the one thing, though, that the consultant in Indiana told us, but she was pretty loud and clear, was that it has resulted in, she thinks, or the state believes, in really helping incentivize the payment of the premiums for that particular category. So, I mean, when you look at your health independence program participation, which is low here, you know, there's a question in our mind when we looked at this, is how do we incentivize at least them taking responsibility for some aspect of healthcare, which if they move on and you want them to move up that ladder and they're in the 138 and they start to move up, they're going to cover, there's going to be some costs. So it's really that type of thinking. But I mean, again,
Right.
could go either way.
All right, thank you. Thanks, Mr. Chair.
The premium collection issue is, there are administrative costs to collect premiums.
John, we got one more. Senator Chesterfield, you're recognized for a question.
Yes, thank you. I tried to read the whole thing last night, and I hope with comprehension. I read that to incentivize, if an individual made 2 trips, I read that somewhere, I'm sure in there, if they made 2 trips to a physician, then there was a waiver of premium. Did I misread that?
I'm not
It's somewhere in here.
It may be that that was the Indiana plan, but what we had recommended was just to make that beginning trip.
Initial trip.
Yeah.
If, for instance, for those of us who are in the school employee and public health thing, we have to do the 1 physical a year, and now we have to do a health survey. So I'm trying to get to, when I read that, it intrigued me, because it said once you did those 2 things, I was interested to know whether it was consecutively, was it annually, how did that work so that the individual was able to get that premium waived?
So it was an annual visit, and it was an annual survey.
Okay,
So that was all that was required. It wasn't 2 visits.
okay, thank
But,
you.
Yeah.
Just 2 positive
But
steps.
that means you read details. That's good, because that was in
I
there.
read this whole thing after I got it yesterday. Thank you.
Okay, the premium issue is one, Indiana does not have costs associated with the premium collection because the carriers collect the premiums. And that's one thing that we recommended. If you remember, we want the carriers in this state to do more of being able to at least be more involved in the coordination and some other activities, and that would include administrative costs with collecting the premium. Iowa, however, does collect in the state the premium, and you can see what we had found when we did the research and actually spoke to the state. This is real time, and they just started this, so this is a good barometer for you all. The cost of the IT support was $20,000 monthly. There was a PO box to maintain the addresses of $40,000, maintenance, postage, all of that, and premiums collected are $476 out of the $1,000,003 that's been invoiced. Now again, that just started, so it's really begin. Phase 1, they're anticipating about $500,000. So this gives you an idea